Today, Dr. Aubrey Miller is going to discuss what is the demand and the zeal for disaster response research at a national, federal level. Dr. Miller has experience with working in the FDA, with the EPA, with NIEHS, and it is just a pleasure to have him. Dr. Miller, thank you for coming.
Thank you, Erin, and thank you for having me. So I'm from NIEHS, National Institute for Environmental Health Sciences. We're one of the 27 NIH institutes. Like most of the other NIH institutes, we have an intramural research program, which is our bulk of us at their campus, about 600 people doing intramural research. We have extramural funding, centers across the country and grantees and internationally. We run the National Toxicology Program with partners from NIOSH and the Food and Drug Administration. But we also have what's called the Superfund Training Program and a worker training program. So let's just talk for a minute about the system. And the systems really comes under these two acts. One is the Stafford Emergency Response Act, which when things are declared a major disaster, you hear the president do this declaration, and they're going to have a system set up that all the agencies have a little place at the table, and it's a response system. And in the National Contingency Plan, which is what EPA and the Coast Guard run under, that's how they do cleanups, how they do emergency response, how they do oil and water responses under that authority. So here's our system, which works. It works well for response, and it was built for response. There's a timeline, preparedness, getting ready, the disaster itself. Well, what do we do? That's the focus of the system is the response. And recently, we have now a recovery framework, which started in 2011, and Hurricane Sandy came up under that a little bit, and we're starting to move into that phase now with the Hurricanes Maria and Irma and Harvey. However, science and research support is not part of the system. It is not built in. We were really focused on the acute response, but not the scientific components of underpinning that acute response and the recovery and the decision-making that goes with it. So one thing is just every disaster, whether it's local, something small, whether it's a manganese fire in a factory or the floods, have really important questions that we don't get at. But each of these situations, whether it's Katrina, I worked on still, we'll talk a little bit about that, the World Trade Center, the Flint, Michigan, as folks recall, the Zika and Ebola situation with an infectious disease, of course, the recent hurricanes in California's ongoing recent fires continue to be complicated. So all these questions, I mean, really fundamental stuff from the community, is it safe? And that's what folks really want to know is, well, what is it? Should we be looking at? What do I want to know for my kids? What do I want to know for the workers? What do I want to know for people reoccupying the area? For whom, what, where? The longer term, the physical, mental health impacts, safety of homes, residents, workplaces. Some of the focal areas of research that we think about are what's the exposure? Who's getting that information? How well do we understand it? Physical and mental health effects. Vulnerabilities and resilience. Start talking a lot more about resiliency. Well, what does it mean to be resilient? Is it personal resilience? Community resilience? And what are we talking about specifically? What are we measuring? What are the metrics of resilience that we should be thinking about? Value of our interventions, mitigations, and strategy, including those that are on the clinical side. So when the H1N1 occurred in the United States, we gave out a medication called peramivir. I was at FDA at the time. And we did this under what's called an emergency use authorization. The medication wasn't approved for that indication at that time, but it was ready to go. It was antiviral. So we gave it out around the country. The government had no way of getting the information back about whether that was safe and effective. There was no system to do that kind of research, even though we were giving out the medication. We could try to get some adverse health reporting, but there was no system in the United States. The Department of Health and Human Services was livid because they didn't have an infrastructure to actually collect that, even though we were giving out that. So things like that, it applies consistently across what we're talking about, from environmental health to the clinical research side of health. So what are we typically, from the environmental health side, thinking about? Kind of data? Well, certainly there's the earth sciences side of the house. We don't think about these guys a lot, but they're absolutely essential to understanding contamination, where it's going, how it's moving, what our exposures are, and then understanding the exposure side, and then, of course, the health research. Putting it together into kind of a risk assessment paradigm. This is a classic EPA paradigm, except without this circle. When we talk about it from EPA, would be kind of the risk assessment, risk management piece. The research is fundamental. It's the hazard ID, right? And I just talked to you about a bunch of different exposures. Well, what was the World Trade Center? It was a complex mixture of exposures, from rocket fuel to dust to asbestos to volatile organics, etc. I think a real serious and significant research endeavor to understand that, not only the exposure, but understanding the hazard ID. Moving into risk assessment, the dose response elements of it, exposure assessment, and then really into the public health, not so much a regulatory situation for disasters, but really translating it to public health and decision making. So let's talk a little bit about some disaster research. And mentioned the World Trade Center, so here it is. The widespread contamination. We identified a wide mixture of exposures with USGS and others that were doing aircraft and overview, having people on the ground, and a range of different concerns. And what we saw, unfortunately, and this is just some of the research that NIEHS was leading, and he's leading the program on some of the medical research going on, about the ramifications. And these are workers. So you can see 28% with asthma, 42% sinusitis, 40% lung disease. Well, really high rates of depression, post-traumatic stress disorder. And so in this work population, we didn't capture the community population of all those people around it and their longitudinal effects. There's some studies, but it wasn't really done. But at least you can kind of see, so here's some applied research, right, post-disaster. We don't get it very often. Gulf oil spill, it's another model to think about in terms of research. The oil spill was huge, right? So 11 workers killed and 17 injured and 19 survivors, and affected 4 states. And there was little known about the effects, both in terms of kind of workers and in terms of the communities that were affected. Only a few handful of studies and use of dispersants and all sorts of stuff. So there were about 130,000 people involved in cleanup efforts. It's not really workers; they were people that were, had been doing other stuff, and now they're cleaning beaches. And guys that were in fishing boats who are now out there soaking up oil. NIEHS went out and started doing a lot of cool stuff with their HAT program and trying to get us some, get information about what the exposures and risks were for populations, and a range of concerns. I won't spend time on all the various ones, from dispersants to exposures to burning, and this went on for months. So one thing we did, and I kind of use this as a bit of as an example, which I think is cool as a model, from a standpoint of what could and should be done with disasters, is thinking about the assets. So at NIH, we have intramural research, and so our intramural research epidemiology program kind of picked up where NIEHS was and started trying to think, okay, let's do a longer term, longitudinal epidemiology study of some groups, and they focused on the workers. And so they developed a longitudinal epidemiology study on intramural. From the toxicology research, trying to understand what the exposures were and what some of the stuff in the water was, we banded up with the National Toxicology Program and other groups around the country to start doing some toxicology research to understand that element. So this is the Gulf study, which we did. This is the intramural study. So this is a large-scale study of workers. So we posted this, about 32,000 people involved. We did the whole medical assessment. It follows up in clinical exams. And we put that in concert with the extramural side, the extramural funding side that was funded by a pooling of a number of NIH institutes, pulled money together to develop this. So, and this was 4 academic centers and 45 community organizations. The community was critical. Trying to do disaster work without the community being involved from essentially the get-go is foolishness, and it's not going to, you won't be effective. So they really identified what their areas were, and the workers that we were worried about came from these communities. So if you're going to have a conversation about doing worker-related research without having it connected to the communities and the community organizations and these universities, they kind of took the charge of it, and they tried to answer questions that were critical. They didn't want the questions answered that we were necessarily concerned about. They wanted their own questions. What had to do with food safety and children maternal health and community impacts and resiliency and use of recreational facilities and coastal lands, etc. There's a whole series of things that they began. So here's one, and this had to do with food safety. This was University of Florida, and they had kind of an academic, community-based thing, and they were really concerned about the seafood safety, and they felt that the FDA's kind of assessment of the risks for seafood safety was inadequate because they ate differently. They ate a heck of a lot more seafood than those estimates were, and they ate different seafood. And so what they did at the University of Florida is they worked with the community, and they collected the specimens, and they collected the amounts of food that they ate, the types of food that they ate, and they contributed to it. And then working together and with the toxicology program, they actually determined it was safe. It was a great validation for that, and a great validation to understand what it was and being part of it. The Ebola situation again challenges us in a whole different ways, and we don't think about it from environmental health, typically from infectious disease. But infectious disease got to be there somewhere, right? So Ebola comes up, and now you have, this is the apartment in Texas, where they tore the apartment apart, and they actually took it down to the studs and everything else, and then they had a huge thing of getting rid of everything because people didn't know if it's infectious and it's going to kill me, so what do I do with it? So it's the fundamental understanding of another hazardous agent, in this case, an infectious agent. But how does it move through the environment? What's its persistence on materials, right? So if it dies in 24 hours, you just don't need to tear apart the apartment, right? So all these decisions were fundamentally made about understanding exposure, agent, infection, and transmission. And then the whole issue translates to worker protections, not just healthcare workers. Much of the system was focused on healthcare workers, all sorts of workers up and downstream that need to have understanding of what their risks are. You know, the Congress was asking, and the first thing they were, I think, grilling CDC was, well, if I got on a bus and the guy had it and he was sitting on the bus before me, will I get it? And the question was, well, I don't know. Maybe I do know. We're not sure. Our epidemiology was in Africa, and it didn't really address these questions. And so, fundamental opportunity for applying our research. Let's talk about how we might improve it and why. So, we talked about the research that's applied, and those are some instances, and there's not many instances where we do good disaster-related data collection and research. The system's not set up, and nobody owns it. Right? So the federal side, it's, EPA has a piece of trying to do what they do on the regulatory side, and the agencies have their programs, but nobody owns it. And thus, and it's not funded by FEMA, it's not funded by the government, the people try to contribute. There's not really a system. And so we're late, we're slow, or we don't get it. There's no formal way to activate and coordinate research. It's difficult to fund it. Slow reviews of protocols was a big issue. That happened with the H1N1. There was no IRB during the H1N1 situation that we could actually get it through to start collecting data. Ethical issues and challenges are not addressed, and people go, I'm not sure about the ethics of it, should we not do it? Lack of ready-to-go tools and protocols, lack of trained researchers. We're going to start getting people to do this. Who's going to do it? Lack of inclusion of community stakeholders. What are you getting? Oh, like Flint, Michigan. Well, you're coming into my town, you're going to start getting data. How am I included or not? Is it working? Environmental exposure data typically missing or not helpful. So there was the H1 flu. We didn't get the data. The IRB issues, no treatment. Deepwater Horizon took us 9 months to start fielding that. Hurricane Sandy was 11 months to start getting some work out. Zika response, even with pre-existing cohorts, took 4 months plus. Here's just an example of the oil spill and what happens with exposure data. So a lot of data was collected. There was tons of data collected by NOAA, EPA, NIEHS collected some of the best data. BP collected a ton of data, over 25,000 full shift air measurements, but no individual exposure data. Differing methods, sensitivities, measure exposure, multiple data sets. Wasn't collected for the purpose of understanding human health issues and impacts. It was collected for all sorts of differing purposes. We spent many years trying to reconstruct this data. The community-based data was almost non-existent. So this is really little. This was really focused on kind of the worker side. So an article came out in 2013. We had been kind of working on this behind the scenes, obviously, for a while, but we used this as a leveraging point. So this was the director of CDC at the time, Tom Frieden, and Francis Collins, and the HHS Assistant Secretary for Preparedness and Response, Nikki Laurie, and basically threw down the gauntlet and said, we got to do better. We really got to do better. This information is critical. We've been having public health problems. We've improved our acute response system. We got to do better to get the science and data. So subsequent to this, we started to work on our program at NIEHS. We basically say, well, what can we do in this space that makes some sense? That we could start to pull together some things to empower us, our intramural program to some extent, and our partners. And it's just thinking about your partners. Who are your partners? Who do you work with? And how do you think about creating some tools or opportunities for them to participate? We're not going to turn our partners, which is our researchers, our grantees, and our centers, which is about 60 around the country, into emergency responders. But we have to create a way for them to participate in a way that's functional for them. We have to allow them to bring their skills, their experiences, and their relationships. So we basically started thinking about, okay, we're going to focus on how do we understand when something happens what needs to be researched, the data gaps and research priorities. How do we prove some of the processes, funding, IRB issues, other things that are process-oriented, to like make it better, faster, smarter. Data collection tools, well, those should be low-hanging fruit. One of the big issues back in '97 was mold, right, of all these flooded homes and areas. And we didn't have good tools to understand about mold exposure. We go in and we tear up people's houses all the time. We spend billions of dollars based on what we feel is mold, and we don't really understand why. I mean, who's at risk? What are we doing this for? Mold's in our environment all the time, right? But we're tearing up our houses, and we're worried about it, and we're telling people not to do this, is that. Who, what, where? We still don't have a great system. We haven't collected that information. So trying to get the tools together to empower this. Engagement. How do we engage each other better? Since there's no system to allow us to do it, how do we figure out an alternative universe which allows us to engage and to integrate into the emergency response system? So the emergency response and management system, basically, we're not interested in having research. Well, yeah, you are, because the World Trade Center should be clear that you want to protect your guys, and you also want to help your communities, and also you're going to have to answer questions when your community comes back and go, is it safe? Can my kids go back? Can they play on this playground? It just flooded. Can they go back here and play? Oh, now I'm interested. Well, somebody else is there. We're all interested. So it's a matter of understanding it, but it's a matter of figuring out how we integrate into that emergency management system and doing it early. You can't do it during a disaster. So you're going to have to think about those relationships, that engagement, that integration ahead of time. And one thing about public health departments, as we started getting into it with them, they're interested in helping, but they have no bandwidth. The academic community has got incredible bandwidth, and they have incredible resources in the sense of they're here, and we can have them help do this. So I won't spend a lot of time on identifying gaps in research. There's it's hard to kind of think about it too, but we do it. Everybody does this in the federal agencies and the health departments when something happens. We're all thinking about, well, what happened here? What got released? What do we know about it? Who's looking at and the community is doing this too. They're all going on PubMed or the National Library of Medicine, and they're looking up stuff just as fast as we are. And folks remember the West Virginia chemical spill, right? So it was about a chemical that was released into the drinking water of Charleston. 300,000 people, and they had been drinking it for several days. There was almost no data, and they knew it too. So you're trying to give people reassurance about a chemical with almost no good toxicology data based on animal studies. So they're getting it fast. So how do we understand this? We've developed some things. There's a National Academies Standing Committee that we've been using for some work, but it continues to be. NIEHS actually published a paper about thinking about some of these issues. So some of the things that we've built. So we started looking on some low-hanging fruit was infrastructure. It should be simple. pull together the surveys, questionnaires, and tools and guidance forms that have been used that are publicly available. So we spent some time, we went through 10,000 publications. One thing people don't publish is the tools very often. So we got some, and we got some websites, and our colleagues in other federal agencies who are producing materials like NIEHS and other groups have materials and have been putting it together. And when something happens, people don't know where to go for it, but we started to pull it all together. So we created a website of these tools and tried to increase the speed and quality of epidemiologic and clinical research, promote standard measures, replication, and cross-comparisons. Simple stuff. So if something happens, and I use a different questionnaire to assess mental health outcomes than they're going to use in LA for that, I'm going to get entirely different answers, and I'll never be able to do any comparisons. So that's what we were seeing in all of these situations. By starting to pull it together, we can at least get some standardization and improvement. One thing we did, too, on the tools that we ended up incorporating, about 345 at this time, is we put in the metadata with the different tools. So what do we know about it? When was it used? What's the purpose of use? Populations of interest, languages, reading levels, special interviewer training, history of use, ease of use, the availability, and where it's at. So we spent a fair amount of time trying to update and keeping this up to date. Our partner is the National Library of Medicine. We're also working on trying to make these tools so you can take them from the research community and build your own. And that's kind of our vision, is to just make it available and let you build stuff with it. It's no good to us to sit on a website unless you can use it and build something with it. So we're trying to build some of that in. And we make it at the info, which is a public health tool from CDC. We have a thing that we're working on at NIH called Common Data Elements, which takes all the questions and making data elements. Another thing that we built, and this was kind of an idea that we said, well, since can we build a protocol, a generic protocol, a big one we call Rapid Acquisition of Pre- and Post-Incident Disaster. A big generic protocol that when something happens, then we just pick out the pieces. So I want to look at respiratory exposures. I want to look at mental health. I want to get blood. I want to get pulmonary function tests. And I want to do this survey. And I want to pull all that together. So we decided we would take and build a big protocol. And we gave it to our IRB. That's the first NIH one that we were aware of that had ever been asked for to approve a protocol that wasn't yet being used. And the IRB said, we only approve them when there's a disaster. They actually went back and they thought about it. And they actually, after about a year, they actually gave us a pre-reviewed protocol. And it got our IRB really engaged to think about this about doing it. So standardized methods, established tools, etc. And really, it was really focused on workers. We have a community-based one now. But, so when something happens, the IRB can rapidly turn it around. They know what's in the protocol. They know all the tools. They're all pretty standardized. But we go back to the IRB with a checklist, essentially, and we give them the information. Well, here's the research setting. Here's the sample we're taking, the accrual, the procedures, the questionnaires of interest, etc. And the cool thing was, so we kind of built it for us to use intramurally, and we don't have a big FD department. We have a small one. We have contracting capacity to do research if we need. But also the vision was, hey, could our partners take this? Could this be helpful to them? And they've been taking it. So we have the University of Iowa, Oregon State, University of Texas Medical Branch, have all taken and created their own protocols, sent it to their own IRBs, and now we have IRB-approved generic protocols, pretty much similar to what we've developed. And, and they put in other things, too, and they're sharing them, so we put it all up for you guys. The IRB, as I said, got interested in this issue and started thinking about it. So they started thinking, what does it mean to review disaster-related protocols and the situations that communities were facing? So we had a meeting in July 2016, a workshop with 60 participants from 23 states to talk specifically about these issues and preparing IRBs for review of disaster protocols, IRB duties, disasters, vulnerability of participants in communities. They took 5 different disaster scenarios and talked about those in breakout sessions. They published this in September 2017. So we're getting into it and starting to think about this, and lo and behold, a lot of IRBs never thought about this really. review stuff and give people things, but they never really thought about all of it. So we've continued since then, and so this last year, right before Hurricane Harvey hit in Texas, University of Texas Medical Branch decided they would take their IRB pre-approved protocol, and they were going to field, the first I'm aware of anywhere, a clinical research exercise. They're going to take a mobile unit, go into Texas City with a simulated hydrofluoric acid release, and they're going to get survey questionnaire, blood, urine, medical testing, pulmonary function, the community, including children. And they pitched it to their IRB, and they did it. And they actually did this exercise. They had to cut it short, but they started to do it. They were going to do it on 8 people. I think they ended up doing it about half, because the next day, this is Texas City, the day after the exercise is what actually happened in Texas City. So they actually had to stop their exercise, but they actually implemented this. And so that was that. So the ongoing activities right now for the IRB stuff is they're moving forward. They're doing a practical guideline they're working on, a compendium, and we're working on a new exercise, which is going to be a population of clinical